Etiology of ARDS as a restrictive lung disease. ARDS is classified as a restrictive lung disease because it leads to stiff, non-compliant lungs that resist inflation. The hallmark of restrictive lung diseases is reduced lung expansion due to intrinsic, lung parenchymal, or extrinsic pleural chest wall or neuromuscular factors. In ARDS, the primary issue is intrinsic lung pathology, which severely impairs pulmonary compliance and gas exchange. There are direct and indirect causes for the etiology of ARDS. The development of ARDS can result from direct pulmonary insults that affect the lung epithelium or indirect systemic insults, which affect the pulmonary endothelium via the systemic inflation. We're going to go ahead and start with the direct lung injury, primary pulmonary causes. These conditions directly damage the alveolar epithelium, leading to increased alveolar permeability, alveolar flooding, and surfactant dysfunction. Pneumonia can be one, since bacterial, viral, fungal, or aspiration related. There is pathogen-induced inflammation that damages alveoli in pneumonia, which triggers neutrophilic infiltration and fluid leakage. There could be aspiration of gastric contents as a direct lung injury. The highly acidic gastric contents cause the chemical pneumonitis, alveolar damage, and surfactant inactivation. There could be pulmonary contusion, a blunt trauma to the chest as a direct lung injury that leads to alveolar hemorrhage, inflammation, and edema. There could be an inhalation injury, such as smoke or toxic fumes. Direct epithelial toxicity damages the alveolar capillary barrier. There could also be a near-drowning experience for a direct lung injury. Salt or freshwater aspiration will disrupt alveolar integrity and promote flooding and surfactant washout. Now let's move on to indirect lung injury. This is the secondary systemic causes. These conditions do not initially involve direct alveolar damage, but cause widespread endothelial dysfunction, systemic inflammation, and subsequent lung injury. Sepsis is the most common cause. Systemic infection triggers a cytokine storm, leading to widespread endothelial activation, increased capillary permeability, and neutrophil-mediated lung damage. There is also severe trauma. This can be burns, fractures, crush, injuries for indirect lung injury causes. The tissue damage releases inflammatory mediators, DAMPs. Damage-associated molecular patterns is what it stands for, that activate the immune system and promotes non-cardiogenic pulmonary edema. Pancreatitis is the release of pancreatic enzymes and cytokine interleukin-1, interleukin-6, TNF-alpha, leading to systemic inflammation and secondary lung injury. Then we also have massage transfusion, transfusion-related acute lung injury, also abbreviated as TRALI. Inflammatory mediators and donor antibodies damage pulmonary endothelium, increasing vascular permeability. There's also drug overdose like opioids, salicylates, heroin, etc. Direct toxicity and respiratory depression contributes to hypoxia and secondary lung injury. Now we're going to talk about ARDS as a restrictive lung disease. In restrictive lung diseases, the primary characteristic is decreased lung compliance due to inflammation, fibrosis, or alveolar flooding. ARDS leads to restrictive physiology through the following mechanisms. Starting with decreased lung compliance and stiff lungs, The alveolar capillary membrane is damaged, leading to fluid accumulation and interstitial edema. Alveolar flooding and loss of surfactant function increases the surface tension, making alveoli prone to collapse, also known as atelectasis. The fibroproliferative phase of ARDS results in deposition of collagen and fibrotic changes, further restrictive lung expansion. The lungs become stiff and difficult to inflate, increasing the work of breathing. Now we're going to talk about VQ mismatch and intrapulmonary shunting. The flooded and collapsed alveoli cannot participate in gas exchange, leading to severe ventilation perfusion mismatch. Shunting occurs where deoxygenated blood bypasses the non-ventilated alveoli, leading to hypoxia that is refractory to oxygen therapy. The decreased lung compliance forces the patient to generate higher negative pressures with each breath, increasing the patient's respiratory effort. As the disease progresses, respiratory muscles fatigue sets in, often necessitating mechanical ventilation. There's also pulmonary fibrosis in late stage ARDS. So in some cases, prolonged ARDS leads to fibroproliferation and permanent lung scarring, which further worsens the restrictive physiology. This phase is characterized by progressive interstitial fibrosis, thickened alveolar walls, and persistent hypoxemia. So ARDS is a classic example of a restrictive lung disease due to alveolar damage, fluid accumulation, surfactant dysfunction, and progressive lung stiffness. It results from direct lung injuries like the ones we talked about, such as pneumonia or aspiration, or indirect systemic insults, which we mentioned sepsis or trauma. And the restrictive nature of ARDS is driven by decreased lung compliance, alveolar flooding, shunting, and eventual fibrotic changes, all contributing to profound respiratory failure and the need for intensive respiratory support.